What we'll do in this panel discussion is to take some common scenarios for the mature systemic T-cell lymphomas. I do have 3 cases, but depending on the time we have and whatever discussion goes on individual cases, we can decide whether we want to go ahead and take all 3 or restrict to only first 2 cases. The minute we see a diagnosis of T-cell lymphoma, for both oncologists as well as for the patients, it's little unsettling. And I think, though Dr. D.K. Mishra is not here, but even for pathologists, the same feeling comes in for many cases. And the reason for that is that there is so much wide variety. There is so much, what you call plasticity in the T cells, as well as in the microenvironment, which makes both the diagnosis and the management really difficult. And on top of that, these diseases are rare. So if you club all T-cell lymphomas, they are only 15 to 20% of all lymphomas. But if we talk about several of these individual entities, it's even rarer. So we don't get to see a huge trial addressing the concerns of patients who have T-cell lymphoma. So with that, I'll begin the first case. I did have few pathology cases, so I'll request all my clinician friends to chip in when we ask for pathology questions. So this is a 54-year-old male who presented with B symptoms, significant amount of weight loss for last 6 months and fever, which was almost 101 and 102 daily for last 3 months, with occasional pruritus. On examination, performance status was 2, and there were bilateral, cervical, axillary, and inguinal lymph nodes. The largest lymph node was 3 centimeters in the left axilla, and the liver was palpable around 4 centimeters below costal margin. Spleen was not palpable. There were no comorbidities. On evaluation, the CBC was showing hemoglobin of 8.4 with normal indices. TLC was 10,500 with predominantly neutrophils and low absolute lymphocyte count. Liver function tests revealed bilirubin of 3, which was predominantly direct, marginally elevated OT and PT, and serum alkaline phosphatase, low albumin, high serum LDH. Lymph node biopsy from the left axilla was suggestive of effacement of lymph node architecture with polymorphous cells. There were interspersed large cells, which were CD45 positive, 30 positive, 20 negative, CD3 positive, and ALK negative. So a diagnosis of ALK negative ALCL was made. Further investigations were done, which again confirmed the suprainfradiaphragmatic lymph nodes. There was splenomegaly with focal lesions, and bone marrow biopsy was uninvolved. With that, I'll just want to ask, this concern which comes in terms of diagnosis of any T-cell lymphoma. How do you think that a histopathological diagnosis of anaplastic large cell lymphoma is made? I know it's a pathology question, but many times we are the one who are at the receiving end, and we need to interpret what is written in pathology report is important or not. So maybe I can just request Hari to start, and if anyone wants to chip in, they can chip in.
Thank you, Manju. But histopathology for a PTCL is even tough for the pathologist. So you're asking me a tough question.
Sympathies with you.
Yeah, but yes, we rely heavily on some of the morphological features that we do come across, and we do encounter certain patterns over there, like you have got something like the lymphohistiocytic pattern, and you have the small lymphocytic pattern, and also a Hodgkin's lymphoma like pattern also, which is over there. And then you have the characteristic hallmark cells that you see on the histopathology, these things. But we rely heavily upon we rely heavily upon the immunohistochemistry over here. Of course, they are pan CD30 positive. And they are, of course, when you're putting the markers with the suspicion, they are definitely ALK negative. And then when you are looking for some of the molecular markers, we can discuss the molecular markers later. But these are the things that will actually make us think that here we are dealing with anaplastic large cell lymphoma, which may be ALK negative over here. But there are so many types of cells that have been described. like there are those fried egg cells, wreath-like cells, and so many other things that have been on morphology described. But with a clinical suspicion, you go on to the immunohistochemistry, which sort of percolates down to give us crystallizing into a diagnosis, and then which is helped down the line with some of the molecular markers also. Yeah.
Thank you, Hari, for showing that bravery and taking this question. Just, I was expecting Dr. Mishra, but just want to show that, typical anaplastic large cell lymphoma, whether we talk about ALK positive or ALK negative, has, more of cohesive pattern. There is effacement of nodal architecture. And you do see these, large cells, we call them as hallmark cells. And once we do the immunohistochemistry, some of the times you may just have these neoplastic cells limited to intrasinusoidal region. And typical IHC, as Hari mentioned, that it's CD30 positive. There is diffuse positivity of the membrane and the perinuclear area. You have loss of one or more T cell antigen. So you can have, 5 negative, 2 negative, or 7 negative. ALK is negative as opposed to ALK positive large cell lymphoma. They do express cytotoxic markers like perforin, granzyme, and TIA. So, and CD8 can be positive in these anaplastic large cell lymphoma. So this is a typical anaplastic large cell lymphoma, but many times it's not very easy to differentiate this from the other, PTCL categories, except that CD30 positivity here is much stronger, and you get to see these cytotoxic markers and EMA positivity, which can help in making a diagnosis of PTCL versus anaplastic large cell lymphoma, ALK negative or ALK positive, depending on the immunohistochemistry for ALK. Is there any subclassification of ALK negative ALCL which you ask in your clinical practice? And if yes, what is the value and how do you do it? So maybe I can take Puneet on this.
So I don't have, unless you do a more molecular classification to look at the differentiation and the prognostic impact, I don't think anything else I have to offer here. It's just that we look at the extra molecules that would characterize its prognosis. I don't have anything more to say on that.
So can I take so there are certain morphological features that have been described in these, like of course the staining pattern, of course, is typically membranous, and there is the Golgi staining region over there which is diffuse, and then you do have these things described like while small lymphocytic variants are more common in ALK positive, but they are seen in ALK negative also. You have the lymphohistiocytic variant and the third variant, which is like a Hodgkin's like variant of ALK negative ALCL. So these are what the pathology is described on histopathology. And of course, we need to corroborate subsequently with some of the other markers to distinguish it from the ALK positive ALCL over here.
Sure. So as Puneet mentioned that, some of the molecular features which can help further differentiate between different ALK negative ALCL. So I'll just take up Dr. Biswas on this. And so what molecular markers, it may not be available or may not be done routinely, but if let's say we have the facility, whether that will help in, further subdividing these and prognosticating.
So good morning, Hari and Manju. So ALK negative is also a heterogeneous group, so they may not behave like the ALK positive we know, but still there is a cohort of ALK negative, especially that is DUSP22. So a rearrangement can behave like the ALK positive, and the other molecular is a TP63 positive, so they will behave like a true ALK negative. So at least these two markers and the TIA, if that is also negative, so there is a cohort of triple negative also.
Sure. So thanks, Dr. Biswas. I'll just highlight what Dr. Biswas just mentioned, that if you look at DUS22 rearrangement and TP63 rearrangement, you get a clear distinction between a very good behaving anaplastic large cell lymphoma ALK negative versus that is, which behaves really poorly. So the outcomes for DUS22 are as good as ALK positive. And in this study, it was almost 85% 5-year progression-free survival as opposed to for TP63, it was around 17%. And the rest, which is somewhere in between, is, the outcomes are also in between. And this can be very well done with the help of FISH itself. So there is probe for DUS22, there's probe for TP63, which can be, evaluated at baseline, and this can, help us in terms of prognostication. What I must tell is that this is all before what we are talking about brentuximab use. So this is the data which is there from the CHOP and CHOAPE, patients who have been treated with CHOP and CHOAPE. So that's where this data comes from. But yeah, it does look like a favorable disease if you have DUS22 rearrangement. Can we suspect this, or do we need to order for everyone? So if you have DUS22, there are certain characteristic morphological features, and this is what we call as, these hallmark cells look like donut cells with, predominant perinuclear inclusion. And as I was discussing that in ALK negative ALCL, you do have cytotoxic, features, CD8 positive and the other granzyme perforin and TIA. These DUS22 rearranged ALK negative ALCL lack that. So that way one can suspect that if you have ALK negative ALCL and you have these features, then you can confirm by doing FISH that whether there is presence or absence of DUS22. We'll move on to, another question, which is, which bothers all of us. We keep on telling our pathologists that tell us whether it's ALK negative ALCL or PTCL NOS. Do you think that there is a clinical relevance in terms of how you're going to treat or how you're going to, prognosticate, whether there is any difference? So I'll move to Dr. Rajiv and request him if, what are his thoughts regarding distinguishing from a clinical point of view between ALCL and PTCL NOS.
Thank you, ma'am. The therapy would actually remain almost similar since both of them are difficult to treat cases. If possible, and as and when feasible, if we are able to add brentuximab into the anti-CD30, then it will be good. But in our cases, we end up using CHOP or CHOAPE. So we have a patient who I've just recently, we just started him on CHOAPE right now. But the only difference would be in terms of prognostication. If it's ALK positive, it's well known that these patients fare better when compared to PTCL NOS, when compared to ALCL. So hence, that differentiation would be necessary for us to prognosticate. And in both of these conditions, as and when feasible, if we are able to induce remission, we take up the patient for transplant. I feel that we would be able to, only the prognosis changes. The therapy would remain more or less the same.
Sure. Thank you. So I agree that treatment won't change much, but differentiating ALK negative ALCL from PTCL does help in, prognosticating the patients, and ALCL ALK negative does better than PTCL NOS. But this is again, as we were discussing more with CHOP and CHOAPE, and we have to see how much it really matters when we talk about brentuximab. So I'll take up another case and then we'll move on to the treatment. So this is a 63-year-old lady who's been having constitutional symptoms for last almost 7 to 8 months. Now for last 1 month, she started complaining of cough and dyspnea on exertion. Performance status is 2. There is generalized lymphadenopathy in cervical region, axillary and inguinal region, but none is more than 1.5 centimeters. Clinical examination reveals bilateral pleural effusion, and there is spleen which is around 6 centimeters below costal margin. The initial investigations show hemoglobin of 5.2, total leukocyte count of 9,800 and platelets 5,60,000. And there is reversal of albumin globulin ratio with high LDH, and she has direct Coombs test positive. The lymph node biopsy here was suggestive of angioimmunoblastic T-cell lymphoma, and that was mainly on the basis of that there was 4 positive, 5 positivity, 10 BCL6 positivity, and there was polymorphous background infiltrate along with high endothelial venules. So this was the diagnosis, and I am not going to put anyone on the spot for this pathology here, and just take up that we have now 3 types of T-cell lymphoma, which are under the category of follicular helper T-cell lymphoma. So I'll discuss that, what those are, but just a question. So here is a more than 60-year-old lady with significant constitutional symptoms, compromised performance status, what additional workup would you recommend in her with the diagnosis of AITL on lymph node biopsy? Anything additional would you suggest? So Hari, I can start with you, and then maybe we can go around to Puneet and.
Yeah, so basically the workup doesn't differ from what we would for any of the lymphomas that we approach. We would like to stage the disease, and also more importantly in this situation, try to distinguish it whether there is an angioimmunoblastic T-cell lymphoma, because marginally they may do better than the peripheral T-cell not otherwise specified. But that is again in terms of the prognosis, and also so staging is important over here. And sometimes if you have a more local regional disease or early stage disease, there is a suggestion that they may do better, and some sort of a treatment in terms of even using epigenetic therapies like azacitidine, hypomethylating agents, etc., might benefit these patients. But I don't believe that there is any difference in the way that we work up these patients as against any other lymphomas. And there is a propensity for bone marrow involvement over here, definitely.
Puneet, any difference of opinion? And I can see Dr. Pankaj is also here, so I'll catch Dr. Pankaj also.
From my side, I think I agree with Hari sir. No major additional workup. I mean, those patients who might be Coombs positive, we sometimes tend to do an autoantibody panel. But other than the bone marrow and a PET CT, that's I would opt because the treatment probably will not change so much. So I wouldn't offer at least more than what is being already done.
Is Dr. Pankaj around?
So yeah, I think generally in the first patient also, which there was also albumin globulin ratio which was altered. So here also it is altered. So it is good idea to do a serum protein electrophoresis, immunofixation, and immunoglobulin levels in these patients. Although it is not, your therapy may not change very much, but if you do these run the electrophoresis, I also prefer to do ANA in patients who have AITL. And if these are positive, many of these patients actually respond very well to cyclosporine therapy, which generally you do not give upfront. It is only generally in the relapse setting, but you have your options in front of you. In PTCL or AITL, where we know the outcome is not very good, whether you use CHOP or CHOP therapy. So as just for a more understanding of the illness, it is good idea to do autoimmune workup, ANA and serum protein electrophoresis in these patients.
Thank you. So this patient, and as I said that this is what everyone wants to do, and as Dr. Pankaj added that we want to have immunoglobulin levels, SVP and ANA. Does anybody perform any molecular test in patients who have AITL?
So yes, ideally, so we need to rule out EBV associated. There are certain additional molecular markers like IDH2 and certain others like RHOA or something like that.
So the RHOA is almost uniformly mutated in these patients, and also that I forget the TBX2. Manju, you can correct me. That is also probably sometimes positive, and patients who have the TBX2 probably do a little worse than the other. But I'm standing to correction because this is just something that I've read a little while ago.
No problem. I think we're all in the same boat. Everyone does the same thing. So as we were talking about the follicular T helper cell kind of a lymphoma, in there are three categories. And depending on, if they typically have, this is the panel which is recommended. So if you have CD30 negative or variably expressed, you do CD4. And the next panel include all these T follicular helper cell markers, which is BCL6, CD10, 20, and CXCL13 and PD1 and ICOS. And if you have two or more than two of these follicular helper T cell marker, they come into this category of AITL or nodal PTCL or follicular T helper cell type of peripheral T cell lymphoma. And if you have less than two, then they fall in the category of PTCL. And as we were talking about the molecular markers, as Hari and Dr. Biswas both mentioned, that the ROA is something which is, quite sensitive and specific for AITL and follicular T helper cell lymphoma. But more than that, it's the IDH2 mutation, which is typically seen in patients with AITL. So more when we have diagnostic dilemma, probably this can help us. As of now, we are not distinguishing anything which is, biomarker-driven therapy fully in the field of peripheral T-cell lymphoma or AITL, except for, looking at CD30 positivity. This doesn't have clinical value, but yes, it can help us in making the diagnosis when you have other features which are not really completely fulfilling, because we know that AITL over a period of time evolves. It may not have the typical morphological features what we are describing here, and that's a place where it can help. Everyone said that PET-CT is needed and bone marrow biopsy. Completely agree. For all T-cell lymphoma, PET-CT has significant FDG uptake at baseline, so that should be considered. There is suggestion that total metabolic volume can have prognostic implications, but again, not validated in any prospective studies. PET-CT really doesn't pick up completely the bone marrow biopsy. So as opposed to Hodgkin's and to a certain extent in DLBCL, where one can avoid doing bone marrow biopsy, PET-CT is showing or not showing the disease. Here in T-cell lymphoma, it's important to complement PET-CT with a bone marrow biopsy. One additional thing which we do in our patients, and we have seen a significant number of AITLs having CMV DNA viremia. And these patients do respond to antiviral therapy. We do use ganciclovir, not as only therapeutic options, but that takes care of a lot of their B symptoms and constitutional symptoms. So we do CMV DNA in these patients. So coming on to the workup for this patient, we had supraintradiaphragmatic lymph nodes, which were non-bulky, as it was evident on clinical examination too. There were bilateral lung nodules, pleural effusion, ascites, and there was marrow uptake in the multiple vertebrae and pelvis. Aspiration and flow was suggestive of bone marrow involvement. So question is, how do you prognosticate peripheral T-cell lymphoma in general? I'm not talking about NK T-cell lymphoma, I'm talking about peripheral T-cell lymphoma. How do you prognosticate, and do you differ from what you use in the aggressive B-cell lymphoma in terms of DLBCL, or you use the similar prognostication methods? So again, I'll start from Puneet and then go to others.
Yes, thank you for the question. I think it's the staging which is probably going to matter the most. The bone marrows, the PET-CTs, and then when possible, do the molecular markers, and that because our treatment panel will probably remain same, CHOP or CHOEP, and then followed by an autologous transplant if ALK negative PTCLs, or even if it is a PTCL NOS. That's how I would approach. In an ALK positive patient, obviously there are no need for an autologous transplant upfront. Just continue with CHOEP and then follow up. That's what I would do.
So, any differences of opinion, Dr. Biswas, Dr. Rajiv?
If it is a PTCL NOS, again, so that becomes a molecular typing of GATA3 versus TBX21, because GATA3 will be more of a bad disease. So where there are newer therapies like the PI3K kinase inhibitors, and if it is a TBX21, so we know that they will do good, and we have novel agents like the JAK2 inhibitors or the STAT3 inhibitors.
I would just like, sorry ma'am.
Please.
This is technically what we're saying is correct, but actually in practice, like in a regular practice, how much are we able to do these tests? In the sense that whenever we have this, we have a ALCL, or when we are happy that we have been able to differentiate whether it's a PTCL and an ALCL, and then afterwards go ahead. So the prognostication, like how we just discussed, is that again, if the marrow is involved, it's a much more poorer prognosis. We're not going to be able to give the full therapy. But the other molecular markers, are we getting it done in regular practice? Is it actually practical? So in what Dr. Biswas has told us, it's very perfect in the sense to be academically sound. But in practice, may I find out, like, what are we doing? What are we doing? How are we actually
I am with you, Dr. Rajiv, on this. So we end up just looking at the basic clinical parameters, the radiological parameters, and the blood parameters, what we usually use in prognostication. Coming on to the molecular or further subtyping based on the molecular parameters. So except for DUSP22 and TP63, which we use, nothing additional is done in the routine clinical practice for if we club all peripheral T-cell lymphomas together. So yes, for academic purposes, for putting them under a specific category of PTCL or in follicular T helper cell lymphoma, we have these facilities, but you're absolutely spot on that the management stops at just distinguishing them and planning therapy based on the clinical, biochemical, and the radiological parameters.
Madam, what are you sending the marrow? Are you sending peripheral blood? Are you sending on the lymph node? How are you actually checking for these molecular markers?
So for DUSP22 and for TP63, we do it FISH on the lymph node biopsy.
Okay.
Yeah.
And any particular, all labs are doing it, or is it only in a research center like Tata?
So I think this probe is basically a FISH probe, and any particular center which has relatively good amount of lymphoma volume, I guess they have. So it's not anything which is limited to TMH. So okay. That's something which, and it's not that for all patients we do it, because even for FISH, there is cost involved. So unless we are really thinking of whether to continue treatment or not, so very select subset where we request for doing these markers.
Thank you.
Yeah. So what I was actually trying to get is the clinical prognostication which we are looking at. So IPI which we use for, or age-adjusted IPI which we use for diffuse large B-cell lymphoma. As opposed to that, there are several prognostic scoring, and as you can see on the slide, from PIT to modified PIT to international T-cell index to T-cell score, there are several features, and as you can rightly see here, that none of them have molecular markers included, except for one which has Ki67 of more than 80%. So rest everything is basically based on clinical parameters or the biochemical parameters, which again goes on to say that we are still understanding most of these molecular markers and their clinical utility for PTCL overall. So this is what is done. I'll move on to the treatment part. And as our first patient, who was LCL ALK negative in his 50s, has stage 3B disease with an IPI of 3, and if we look at the T-cell score, that is 3. So how would you manage? And I'll start with Hari, and I'll just try and understand that if the same patient was young patient in his early 20s, whether your management would change or it will remain the same. So ALK negative ALCL, this patient and the younger patient. Hari, and then I'll go on to the others.
So thank you, Manju. And the thing is, I would not treat it differently if it was older patient, but you had put a clause about younger patients. So in older patients, I would just go ahead with the standard therapy with CHOP over here, keeping in mind that if they are having a good prognosis, they are bound to do well with the CHOP protocol. But if they are if they do not have those favorable profile in that negative, then even though there is not any strong data to say that intensification of therapy works, I may be skewed towards using a more intensive therapy. So I know that when I was there at Tata, we used to use more intensive protocols for young patients, ALK negative patients below the age of 30. We used to think about using patients with the BFM 90 protocol, which was an intensive protocol over there. But largely, we have become a little wiser and realized that maybe using most of the patients would do well with the standard CHOP protocol over here.
I can see Dr. Pankaj is still with us. So, sir, I would like to ask you, what would be your opinion on treating this patient? Hari said CHOP, and let's presume that we have brentuximab available in India. We not really need to import, so it's available and you can prescribe. So what would be your preference? And
you are right. You are absolutely right. So if brentuximab is available, then obviously brentuximab with CHP therapy is kind of a standard for ALCL nowadays. Although Hari is right that, out of our 100 patients, probably 99 will still go for CHOP therapy or CHOIP therapy only. But definitely, if brentuximab is available, I would like to use brentuximab based on the available data.
So I'll take an extension of that question itself. So if you're using brentuximab, would you be looking? So we know that ALCLs are all CD30 positive, but if you're talking about, let's say, PTCL in this scenario, would you be looking at any particular cutoff for CD30, or any expression would be fine?
So I feel that ALCL definitely brentuximab, irrespective of expression, but in PTCL NOS, unless the expression is more than 30% or 40%, it's some study says 30%, some says 40%. There I would not. There the use of brentuximab is not very, I would say, forthcoming, but in ALCL definitely.
Sure. Any difference of opinion, Puneet, Dr. Rajiv?
Madam, if I would ask, it's like Hari Menon sir mentioned that he would like to do CHOP, and since that, why not CHOP? It's a young patient, so you hit him hard. You know that with CHOP, these patients would have some amount of remission for probably 6 months, and if you're unable to take them for a transplant, then it will be a very short-lived remission. So wouldn't you want to hit him with a much more harder regimen? So
what harder regimen would you recommend? CHOIP?
CHOIP, in the sense that, yeah, CHOIP.
Okay.
Can I interrupt? Sorry.
Yes, please.
Because everybody's here, I would actually like to ask, what about the autologous transplant in a situation like this? Post CHOIP, if you are going to ensure ALK positive, yes, there is no role for an autologous consolidated transplant. But what about all the other types of PTCLs?
Thank you for bringing that question a little ahead, which I was coming a little later. No problem. Yeah. So I'll start from the transplanters.
So I believe that if you are with the data that's available, ALK negative with a DUST-T2, they behave as well as an ALK positive ALCL. So there's really no need to there. We are not sure about ALK negative patients who are negative for DUST-22, but then intuitively we tend to use a more intensive protocol in the beginning, and then if you're using a more intensive protocol and if they fail that therapy, I don't believe that autologous transplant is going to add too much, because if you look at the story from the peripheral T-cell lymphomas also, again, it is a little divided regarding the role of or the benefit of doing an autologous transplant in peripheral T-cell lymphomas. And if you were to look at it more in depth, those patients who actually responded well to primary therapy, they were the people who went on to benefit with an addition of high-dose chemotherapy and stem cell transplant. But if those patients had an early relapse or they did not fully respond, transplant did not add too much to the outcomes of these patients.
I'll come back to Dr. Pankaj again.
Yeah, so definitely for PTCL and ALK negative, patient should be offered an auto transplant, whether you use CHOP therapy or CHOIP therapy. Practically, I don't know, CHOIP is obviously a little bit more toxic therapy, but whether it really makes a difference or not, or it is just, a feeling that, if it is a young patient, so, you would like to give CHOIP therapy to that patient instead of CHOP therapy. We all do, I think, in our practice. But I think the important thing is to offer an auto transplant in all these patients who are ALK negative and a PTCL NOS, especially if they are young, less than 50 years of age.
So this is, the basic, thought most of us have that, CHOIP works better than CHOP. But if you look at, this is the data from where that, the genesis of CHOIP is, and this is retrospective data. And if you look at the difference between etoposide and non-etoposide, it was mainly limited to the younger patients, normal LDH. And it was predominantly, if you see the p-value, it was mainly for the ALK positive ALCL. If you look at rest of them, it's borderline significance, and the p-value here is 0.057. And definitely not for the older individuals, older who are more than 60 and those who have raised LDH. So even if we go by this retrospective analysis, I think the best benefit which is limited is to the positive. Those who are younger and normal LDH is where probably etoposide works. But I agree with Rajiv. Many times we feel that CHOEP is going to do better, and especially those who have extensive stage of disease, we tend to use CHOEP, especially if we don't have feasibility of using brentuximab. Coming on to the question of DUS22 here, I think if you have DUS22 positive, probably you can avoid using brentuximab there. Probable. I don't have any hard data to say that it's going to be less effective there. But since the outcomes are quite good, even without using brentuximab, that's probably the set where you would want to use that money of brentuximab and do fish at baseline and see whether you can just do away with CHOP and CHOEP in these individuals. Another point of what we were discussing is whether younger patients, we want to do anything differently for this subset. So actually, what we do in up till 25 years, which we treat more like AYA and on the pediatric protocol, we've been using Alcl 99. So as Hari rightly said that when he was there, we were on BFM 90, but the challenges were of high dose methotrexate, the mucositis, the cytopenias. We've moved to Alcl 99, and the basic difference there is you use a lesser dose of high dose methotrexate there, and 1 gram per meter square over 24 hours and no intrathecal therapy. So that's one advantage of Alcl 99. You have lesser toxicity, and data in pediatric with Alcl 99 is quite good, almost 70% plus 5-year survival, and this is even in the advanced stage disease. So that's one difference which we do. And when we were talking about the brentuximab, and now we have long-term follow-up 5-year data for the Cyclon-2 trial, and you have both PFS and OS benefit. But I just want to highlight that this is predominantly driven by the anaplastic large cell lymphoma. 75% of these patients were anaplastic large cell lymphoma. They used a cutoff of 10% for CD30, though in the later analysis they said, even if you have CD30 which is lesser than that, it really works. What it clearly shows that it doesn't work so well for AITL. We don't know whether it's truly the result of the low numbers. That's the reason why there is no difference, or it's it's really that the CD30 expression is really very variable here, and that's the reason why brentuximab doesn't work. So this is for the data. Novel agents, and as Dr. Pankaj was mentioning regarding cyclosporine. So I'll just come to that AITL lady who's 62 years and has all the features which say that there is significant autoimmune burden in terms of autoimmune hemolytic anemia, reversal of albumin globulin ratio. There is polyclonal hypergammaglobulinemia in that lady. There was no monoclonal gammopathy. So my question is, how would you handle that lady, 62-year PS2, frail, extensive disease? Do you think that the conventional CHOP CHOEP, brentuximab CHOP CHOEP, brentuximab plus CHP, or anything differently you would want to do? So I'll begin with Dr. Pankaj because you seem to have some experience with cyclosporine, and we do use cyclosporine in elderly who are not really fit for conventional systemic therapy. So I just wanted to start with you that if you have all the choices available, what would you pick up?
So unless the patient is very frail, then we still prefer to use CHOP therapy, or maybe you have brought up the option of bendamustine also. So bendamustine actually also is a good drug for T-cell lymphomas. Cyclosporine mostly we have used in a relapse setting, and definitely patients respond very well to cyclosporine therapy. You start with 3 mg per kg and go up to 5 mg per kg. The only problem is that these patients will respond for 6 to 9 months kind of a therapy with cyclosporine. It is not that I don't remember any patient who has gone on for more than 2 years or 3 years with cyclosporine. So generally you in the relapse setting, when you don't have the options, and if they respond, they will respond very well. In the first month only you will see the response with cyclosporine. Their hemoglobin will go up, their symptoms will subside, and even the lymph nodes actually they will go away. So they would respond very well in the first month or so. but the responses are not very long lasting. That's what I would say.
Sure. Dr. Biswas, anything different? Then I'll come to Rajiv.
No, Manju, so I don't have much experience on that.
So I would like to ask, Sir, Pankaj sir, using cyclosporine along with CHOP, are you giving it as a single agent, or you start with along with CHOP and then stop CHOP and then continue cyclosporine? What has been your practice?
No, so our practice is not to use cyclosporine with CHOP therapy. I'm talking of a relapse setting. So in the relapse setting, cyclosporine alone, single agent, as I said before, 3 mg per kg to start with and go up to 5 mg per kg as tolerable. And within first month, you will know whether the patient is responding to this therapy or not. But the patients of AITL specifically who have autoimmune manifestations, as I said, ANA positivity or polyclonal hypergammaglobulinemia or even monoclonal, they generally respond very well to cyclosporine.
Sure.
So, sir, in the second line, when the relapse setting, then you start up with cyclosporine directly rather than going in for a salvage regime, sir, or you try to bring it into control and then shift over to cyclosporine, because we know we are expecting that when there is a relapse, there's a huge amount of disease burden. And so will cyclosporine be strong enough to just curtail that, or you want to use like a Gemox or something like a GDP, bring it down? And what's your thought?
No. So you would see all the large lymph nodes just melting away with cyclosporine. This is so fantastic to see, actually.
Okay.
If the patient respond, they would respond very well. So obviously, once there is a relapse, you need to check it by doing a repeat lymph node biopsy, because many times, in Indian patients, you will have some tuberculosis, sarcoidosis, or many other things. So you need to document the relapse and then start on cyclosporine. There is no need for a salvage therapy.
Okay, nice. Thank you.
Just to follow up on Dr. Pankaj's observations, to me, in T-cell lymphomas, there are two entities that actually respond to cyclosporine. The first entity which responds profoundly is a panniculitis like T-cell lymphoma, which responds exceedingly well, almost immediately with cyclosporine. And the other one is angioimmunoblastic T-cell lymphoma. But there is really no data to say where you're going to. In fact, there's no robust data also for cyclosporine in AITL. But having said that, you try to position it in situations like in the setting of relapse. But always the first line therapy in AITL would always be approaching it with chemotherapy, either with a gemcitabine based regimen or with, as we would for a peripheral T-cell lymphoma. And generally, they respond better when the volume of disease is much lower.
So this precisely, sir, in the sense that what would be, how would you choose? The next question is cyclosporine sounds fantastic. We have never used it as a single agent in the past. So how would you choose your patients for cyclosporine?
No,
is there some?
I don't think so, and except for the fact that it is an angioimmunoblastic T-cell lymphoma.
So, what we do many times with cyclosporine, I'm not sure whether, it's exactly what Dr. Pankaj mentioned, but, anyone who's frail, where we know that for frontline, what we are talking is where we know that giving CHOP or CHOEP. So typically these are in their late 60s or early 70s individuals, where we know that CHOP, CHOEP, both are going to be difficult. And they have significant amount of, autoimmune manifestations, relatively small size lymph nodes all over the body. These are the patients, they have done pretty well with cyclosporine. In fact, for some of these patients, we have used cyclosporine as upfront, but for others who are in that age group, because we know that for most regimens, if you're not consolidating with transplant, this disease comes back within few months. So we've used cyclosporine as maintenance too. These are all n is equal to 1 or n is equal to 2. So I can't say that, cyclosporine is truly effective. But at the same time, we have seen that these patients have maintained their, responses for a long period of time. So this is, don't quote us on this, totally not really an evidence-based medicine with the numbers what we have. But, what I feel that this drug does have some role. And especially where you cannot offer any intensive chemotherapy and transplant, and you're going to have practically the option of palliation, given that you don't have access to many of these novel agents. And, those are the setups where one can use this. And bendamustine is another drug which, for this particular group, which is otherwise not very fit, can be considered if you're not really looking at anything beyond good symptom control and some reasonable disease control.
Manju, I would just rephrase, it's not that any patient of AITL who comes with a relapse, you just start with an cyclosporine. You discuss the option of salvage therapy as well as cyclosporine, and if it is, it is the patient's choice. So, and the patient, as Dr. Manju said, is frail and not very well fit to receive chemotherapy, only then you would start on cyclosporine. It is not, cyclosporine is not a second line agent for all patients. It's only for a select group of patients.
Yeah. And
so how do you choose, sir? So how do you choose? That's exactly, sir. Because I'd be very tempted to start off on Gemox or something very simple, then curtail the disease, and then, like Dr. Manju mentioned, then put the patient on cyclosporine. It seems more thing to me, sensible to me.
I would just say that if you feel that you cannot give Gemox to the salvage therapy, give cyclosporine.
Okay, yeah, absolutely. I would agree with what Dr. Pankaj said, that if your patients, you don't feel that they will even tolerate Gemox. And I must say that Gemox has not done wonders for AITL, meaning you feel good for first 2 cycles, 3 cycles. At the end of 4th cycle, the disease is again started showing its recurrence. So anyone where you feel any kind of salvage chemotherapy is not going to be usable. At the same time, they do not have really aggressive manifestation, meaning bulky nodes, massive splenomegaly, and all those. You can definitely use cyclosporine, and do try in this subgroup next time when you see the patient and tell us what has happened. Maybe we can all collate the data and look at what cyclosporine does in our patients, overall for this subset. So I guess we are running out of time. We probably have crossed 5 minutes. I don't know, Sachin.
Yes, ma'am. We have crossed.
Okay, so I'll just sum up, with 2 things. There is a lot of hope regarding a lot of novel agents. We have some successes with oral azacitidine as phase 2 trial. We need to look at, how it does in phase 3. The romidepsin failed in the phase 3 trial, so we are back to square one as far as PTCLs are concerned with in terms of romidepsin. Probably a single agent in relapse setting, yes, but not for the upfront patient. And for transplant, I just want to point this fact that there is, as Hari said, there's no randomized trial. This is the only largest prospective Nordic data which we have. Those who got CR or PR, they did better if you consolidated them with transplant. So anyone, where we see that they're in high risk category, meaning either in terms of PIT or in terms of IPI or T-cell score, if they're otherwise fit, our suggestion would be to offer them transplant based on this data. You can avoid the DUS22s and the ALK positive ALCL. They won't come in this category, but I guess we know that we don't have many salvage options, so that can be considered, especially if they have not received brentuximab upfront. Even though with brentuximab, those who underwent transplant, there's a suggestion that they do well with transplant as opposed to not having transplant, but no randomized trial here. So with that, I'll end, and I'll really, really thankful to Puneet and Dr. Pankaj and all the other panelists for being here on Sunday. I know it's almost lunchtime. Thank you so much. It was wonderful.
Thank you.
Thank you. Thank you.
Can I take 1 minute? Can I take 1 minute? Now that I see all the seniors on one stage, I'm very tempted to please help me out solve one clinical scenario. So there is one 61-year-old gentleman. He is a known case of PTCL. He had presented almost 5 years back and had stage 3 PTCL not involving the marrow. He received CHOP, CHOEP, underwent an autologous transplant. And 5 years down the line, 5.5 years, he comes back with a new groin swelling. And now again, there is a isolated relapse in the groin with the lymph node. Now my question is, do we redo the CHOEP? Do we offer salvage? Can we offer a second transplant? So I was tempted to ask this.
I'll start with the senior most people. And I'm really not sure between Dr. Pankaj and Hari who takes the...
Hari will pick up the thing.
So we should not speak simultaneously, Pankaj. So see, there's nothing that but if this patient were to come, our general note that lymphoma as a systemic disease will skew me towards offering chemotherapy to this patient because it is 5 years since his primary diagnosis. And I would like to borrow a page from the early stage lymphoma protocols, because technically 5 years is a good time for a PTCL. Probably give him something which is not too intensive, like a gemcitabine based regimen over here. And then probably, if it is a large enough node, consider involved field radiotherapy to that area.
About second autologous transplant, Pankaj sir.
No. I agree with what Dr. Hari. The first thing is obviously to recheck by doing a biopsy, whether it is the same disease which was there 5 years ago, and then giving chemotherapy, and depending upon the situation, either IFRT or a repeat auto, whatever. If the patient you feel is fit, and you can take up the patient for transplant, definitely, because first time the transplant has really helped this patient for 5 years. So maybe that. Otherwise, if not fit, give IFRT after 3 to 4 cycles.
Great.
I'll only
Thank
add
you.
one thing, Puneet, here. PTCLs typically relapse very early. Even if they have to relapse, they relapse within first few years, and typically within 2 years, all the relapses would use. So as Dr. Pankaj said, I would really be keen to look at what the histology is, and whether it's more like those follicular helper T cells which can behave indolently. And you can probably then avoid, doing a transplant. Regarding chemotherapy regimen, I'm not sure whether you want to repeat CHOP or CHOEP. You've already given 6 cycles earlier, so you wouldn't want to, expose more anthracycline here. So
I started GDP. In fact, the patient had taken, I'm being honest, the patient had taken the first cycle and then came to me for an opinion. So I was like,
so I would just, probably give GDP or maybe anything which is etoposide based otherwise. So depending on how the renal functions are and how the overall performance status is, any etoposide based regimen, and then, just give RT, especially if it is more like indolent. And transplant in this setting, according to me, I'm a non-transplanter, disclaimer first. So according to me, may not be really, very helpful, given that the disease has remained well for 5 years time period. So this is all from my side.
Yeah, no, very valid. Thank you, everyone. I think it's been a great discussion and lots of learning for all of us.
Thank you.